Hi, everyone. My name is Ndidi, and I have the pleasure of introducing our speaker, Dr. Booz. Dr. Booz is an attending pediatric dermatologist at Seattle Children's Hospital and is an associate professor in the Department of Pediatrics at the University of Washington School of Medicine. He is also the associate program director for the Dermatology Residency Program at the University of Washington. Dr. Booz was raised in the suburbs of Detroit and received a bachelor's in biology and economics from Kalamazoo College in Kalamazoo, Michigan. He subsequently joined the medical scientist training program at the University of Chicago, where he obtained his MD and PhD degree in immunology. He completed an internship in pediatrics at the University of Chicago's Corner Children's Hospital before joining the hospital of the University of Pennsylvania as a dermatology resident. There, he served as chief resident during his final year before completing a fellowship in pediatric dermatology at the Children's Hospital of Philadelphia. Dr. Booz enjoys caring for all children with skin disorders, but has a special interest in LGBTQIA2S+ health, the effects of climate change, including wildfires, on the skin, and the cutaneous manifestations of primary immunodeficiency disorders. When not seeing patients, you can find him teaching residents, giving talks, working to reduce healthcare disparities, and helping the Seattle Children's Administration meet its carbon neutral goal by 2025. As a gay father, Dr. Booz enjoys watching Survivor and playing Mario Kart with his twin boys. He also enjoys weightlifting, biking, and swimming in Lake Michigan. He cheers for the LVR Golden Warriors, Detroit Red Wings, the San Antonio Spurs, and has adopted the Seahawks as his pro football team. We're very fortunate to have Dr. Booz with us today. Please join me in welcoming him. If you have any questions, please place them in the chat for a discussion after the talk.
Thank you so much for the kind introduction, Ndidi. I just want to make sure everyone can hear me okay. Okay, I'm going to share my screen. And just want to make sure again that you all can see my title screen and not my my notes. Is that correct, Bill?
Yep, looks great.
Okay, great. All right. I just want to thank the organizers for this great opportunity. I really appreciate all that you've been doing over the past 2 years of the pandemic just to help with the dissemination of derm info and insight. It's such a fantastic undertaking, and I feel really privileged to be a part of this, this endeavor. I'll be talking to y'all about dermatology and its intersection with sexual and gender minority or LGBTQIA2S+ health. But before I start, a few things I'd like to do. First is just a land acknowledgement. I live and work in Seattle, which is the traditional land of the first people of Seattle, the Duwamish people, and I honor with gratitude the land itself and the Duwamish tribe. I also wanted to give a huge shout out to the Society for Pediatric Dermatology and the Pediatric Dermatology Research Alliance, both of which have been fundamental in helping me with my career and my goals. I would not be where I am today without them. And also a big shout out to UW and Seattle Children's, especially my division chief, Rob Sidbury, who have always supported me in just being me. That is rare, and I feel very lucky to be where I am. All right, so let's go over our objectives for today. So the first is just to provide an overview of how to approach sexual and gender minority patients in the clinical setting. Then we'll talk about healthcare disparities that uniquely or disproportionately affect sexual and gender minority individuals, and then an update on what's known about the unique dermatologic needs of LGBTQ children. So when I give talks like this, I like to make sure that we're all grounded in the same space. And so the first question just to ask ourselves is, why does it matter? And I think that as Derm and the House of Medicine has really engaged more in the DEI space, we're starting to understand why paying special attention to historically marginalized or discriminated groups is really important. And one of the fundamental aspects of that is equality versus equity. So equality is just the idea that everyone gets the same care no matter what, where equity is more about achieving a specific outcome. And so the resources that are provided to an individual is really based on their personal circumstances. So one kind of simple example of this is if a number of people want to run a race and they only choose and you give everyone a size 8, but people have different size shoes, right? The people who are size 8 may do quite well, while people who have bigger or smaller feet don't. So the idea is not to just give everyone the exact same care, but to tailor it to make sure that we're providing care that helps people reach their best health outcomes. And one example of this, which I'll address briefly later, is, men are not advised by the USPSTF to be screened for STDs regularly, but men who have sex with men are. So again, it's the provision of care that's slightly different depending on the individual in front of you and the circumstances of, who they are. I think this talk is also timely for me personally as a gay man, because we are living in a time where LGBTQ folks are under attack in society and also by our governments. These are just headlines that came from last week. You may have heard about the Don't Say Gay bill in Florida that bans teachers from talking about sexual orientation and gender identity in school-age kids. And then in Texas, where the governor is trying to outlaw gender-affirming care, which is troubling for a lot of reasons. The first and foremost being that LGBTQ children, disproportionately have higher rates of mental health disorders because of the stigmatization and discrimination that occurs to them because of their identity. And beyond that, it really fundamentally strikes at what our agency is as providers, provide the best care possible to the patients who need it. And I'd argue this is really important in light, especially of data that we have that shows that providing such care really has tangible benefits for folks. So there are a number of papers that have come out recently. This is one from my colleagues here at Seattle Children that showed that providing gender-affirming care to transgender children really improves mental health outcomes. Another study from Jack Turbin and his colleagues at Stanford showed that the earlier that starts in adolescence, in fact, the better outcomes there are as opposed to later in adolescence and during adulthood. So when I take all this as a whole, and what I hope to convey to you is that this work, it really asks us to move beyond just like this transactional, like I'm a dermatologist, I am taking care of your skin. It's really inviting us to see the folks in front of us as whole people, right? We don't take care of skin, we take care of people. And I want us to keep on coming back to that because I think it's so important when we do this type of work in DEI space. So, at the end of this isn't just like a DEI checkbox for y'all to mark. You don't get to say like, oh, now I get it. This is the beginning or maybe a continuation of your journey. And it's so important because you may change and you might even save someone's life. So let's get to the demographics. So I'm going to start with a little bit of older data. So this is from 2012, a Gallup report, just kind of identifying what is the population in the United States that identifies as LGBT. So about 3.5% identified as a sexual minority. And at the time, about 0.6% of US adults identify as transgender. One other sort of important nuance that I want to call out to is that about 8.2% of adults at that time reported ever having same-sex sexual behavior. So these are folks who may have identified as heterosexual, but still had same-sex activity. And that's just important because it's really that risk factor that's important for us to consider as providers and dermatologists specifically. And fortuitously, last week, an update to this came out from Gallup showing kind of where we're at now in 2021. And what it showed is that 7.1% of US population identifies as lesbian, gay, bisexual, transgender, or something other than heterosexual. So in the last decade, that percentage has doubled. And getting into the data a little bit more, what you can see is that the majority of folks who identify as LGBT are bisexual, and the folks, as far as adults, who identify as transgender has bumped up just a touch to 0.7%. And this is heartening to me because it indicates to me that we are creating a society that is more open and accepting and allows people to just be their authentic selves. Because I'm a pediatric dermatology, I would be remiss not to talk a little bit about development and how this plays out in children. So the concept of gender identity typically starts to take form in children when they're around 2 to 4 years of age. But many transgender children start to self-identify around 13 years old, though this is certainly not a sharp cutoff. It can happen much earlier, it may happen later. Looking at sort of the demographics when it comes to children and adolescents, sexuality is more fluid. And so folks often self-identify as gay or bisexual a little bit later in the teenage years, 15 or 16. There isn't a ton of data to my knowledge on this, but in one study, 8% of students in 9th to 12th grade identified as being a sexual minority. And a recent report from the CDC, the MMWR, showed that 1.8% of children today identify as transgender. So these are not just sort of like small groups that maybe you will come in contact with. you may be caring for sexual minority or transgender patients in your clinic right now, and it's important to be aware of that so you can provide the best care possible. So what are some barriers to care for LGBTQ individuals, including children? Unfortunately, there is a number of them. The first one is just availability. So we want to have a workforce that can treat, whatever the issue may be, that's in reasonable proximity to folks who need it, and that can provide all the comprehensive services necessary. But in addition to just being available, they also have to be accessible. So when we're talking about teenagers, for instance, and especially for sexual and gender minority teenagers who may or may not have the support of their families, how do they access that care? Is the office located in an area where LGBTQ kids live? Can they access it safely with like public transportation, for instance? Are there insurance barriers that we need to talk about? What about nighttime hours, right? We need to make sure that our clinics operate at a time when kids can actually get to there, instead of like taking off from school, for instance. Acceptability is another potential barrier to care. In addition to just having the space available and the expertise, we want to make sure that the care that we provide is culturally competent, respectful, humble. There have been a number of studies in the medical literature talking about really negative experiences that specifically transgender children have had with their care providers who refuse to identify their gender identity, and just sets up a negative cycle that engages or engenders more distrust with the medical community. We really want to work against that. Are we making sure that we're respecting patient privacy? Are there unisex bathrooms for folks to use? So these are the sorts of issues that we want to be thinking about. And finally, again, we want the care to be equitable. So is everyone that's going to the clinic, are they getting the same care? Whether you're cisgender, homosexual, heterosexual, gender minority, a sexual minority, we want to make sure, again, that the care that we're providing helps each individual that's present in our practice achieve the best healthcare outcomes possible. And sometimes there's other considerations to that's involved with that. So again, it may be socioeconomic. A term that you may have heard about is intersectionality. When I think about intersectionality, the sort of definition that really sticks with me is that an intersection can be a dangerous place. And that's especially true for folks who have multiple aspects of their identity that may be minoritized or discriminated against or stigmatized. And so it's really important that we're really addressing all of those things, because depending on your religion or ethnicity, for instance, those may also play a role in how you are treated by your family with respect to your sexual orientation or gender identity. And really providing all the support that we can possible is important, again, to recognize the whole human being right in front of us. Some folks have argued that gender clinics can be helpful to reduce these barriers for transgender children specifically. It's definitely helpful when there can be sort of like coordinated care in one place. Often dermatologists are not involved in that or not included directly in those clinics. So it's not necessarily a panacea for dermatology, but an important thing to provide if possible. And then, implicit bias is another term that we talk about that you may have heard about more recently in the past couple of years. So that encompasses the sort of activated involuntary assessments of folks just based on one aspect of their identity. We really want to make sure that we're checking our implicit biases against folks at the door. For instance, I've had experiences as a gay man where I've had doctors assume things about my sexual behavior that really it just didn't feel good. And so it's just important, again, to be aware of potential risk factors, but to address the individual circumstance or the individual person in front of you. And we know that implicit bias is decreased through educational opportunities like this and just more interaction with folks who identify as LGBTQ. So it may feel scary for folks who are not used to doing this, but I'm hoping to give you some skills to really talk openly and with humility to your sexual and gender minority patients, and that hopefully makes everything feel a little less fraught. And when in doubt, I'd like to come back to this. You probably have LGBTQIA friends, families, coworkers, people who you really sincerely care about. And when it comes down to it, if you don't know what to do, just think, what would I want for this person that I love? And hopefully that can guide you in your care. So there's two big things that we need to do. Okay, so the first is know the basics. And this is what I hope to, again, help you with today. And then we want to ask for appropriate details from the patient in front of us. Because we don't want the patients to feel like they need to explain every last nuance of the transitioning process, all the things that we should be thinking about with respect to their care. gay men should not have to advocate for getting, responsible medical care, for instance. So we hope that we'll establish the basics today, but then let your patients guide you to help you understand the care that they personally need. So how do we make our practices more welcoming? I'm going to start with tip number 1, and that is to use inclusive language and follow your patient's lead. So again, for folks who are not sort of immersed in the space, I think sometimes the terminology can feel really overwhelming. I think that most people know, for instance, what bisexual means or gay or lesbian. I did want to touch on 2 terms specifically. So one is gender nonconforming, gender diverse. I really don't like the term gender nonconforming because it suggests that there's a way that people should be. But gender diverse, non-binary, queer, they often have similar meanings. Queer is typically an umbrella term that's inclusive of all non-heterosexual and non-cisgender identities. Whereas non-binary or gender diverse, these are folks who identify as neither male nor female, having a gender that's other than male or female, perhaps having multiple genders or not having a gender at all. So these folks typically just reject this binary gender model. And depending on the individual, how they're feeling on a certain day may influence how they, which pronouns that you will use with them. And so it's just really important to be aware of that. The term pansexual is also another one that I think is important just to be aware of. The other way this has been described is it's gender blind. So this is the idea that people's sexual attraction is not limited by a definition of gender or sexuality. Their attraction is regardless of any of those things. They really just love and are attracted to the person in front of them. Let's again kind of make sure we're on the same page, ground ourselves in the same space. Sexual orientation, that refers to an individual's sexual and emotional attraction to others. But again, sexual orientation is not the same as sexual behavior. There are plenty of folks who may identify as, homosexual who have heterosexual, encounters, or vice versa. So again, it's really important to tease out like what are the actions that are happening, not just what is an individual's orientation. Gender identity is a person's internal fundamental sense of being a man, woman, or another gender. And gender expression is a person's method to communicate gender through their appearance, personality, behaviors. And again, it's just really important to know that sexual orientation and gender are related, but they are distinct concepts. So it's convenient to lump sexual and gender minorities into one category. I understand why that happens, but also the experiences and the needs of these populations are quite distinct. So just a quick note about transgender individuals. So again, it's really important just to recognize and to say out loud that gender identity is independent of transitioning medically. Someone who is transgender has a fundamental internal sense of self as a gender that differs from the sex that they were assigned at birth. So this isn't like, oh, I want to be male or I want to be female. These folks know they are, but that doesn't align with the sex that they were assigned at birth. And to just make sure again we're on the same page, transgender men identify as men, but their sex assigned at birth is female, whereas transgender women identify as women, but their sex assigned at birth is male. So how do we start having these conversations? I think the most important thing is just to normalize the discussions that we're having because we're not used to having them, right? We live in a very heterosexual, cisgender, like heteronormative society. And so it's just important to think about like, okay, we're just gonna normalize these questions. And that way it makes us feel better. It makes sure that the patient feels heard and understood. So let's talk about potential phrasing. So I like to, just let folks know when I meet them for the first time, hey, the first time I meet a new patient, I wanna make sure that they're comfortable. How should I address you? What pronouns do you use? If the patient starts using gender pronouns, I would recommend doing the same. If you realize during the encounter that you've been inadvertently like misnaming or misusing pronouns, the most important thing to do is just identify it, apologize for it, change the error, and keep on going. I have never had an instance where I have accidentally misused pronouns where apologies were not warmly received. I think folks understand that we're doing the best that we can, and everyone's trying to do the right thing. And sometimes there are slip-ups, and if we again accept those instances where we make mistakes with humility and a commitment to do better, it is typically well received. With respect to relationships, I think again it's really important not to assume that someone has a partner of the other sex, for instance. So sort of neutral phrasing would include, do you have a significant other? Who did you bring with you today? Are you in a relationship? In general, the most important thing you can do is follow your patient's lead. Terms to avoid. Homosexual, I personally, as a homosexual man, I don't find this particularly offensive, but it has been used in derogatory means or ways in the past. So for some folks, it is a trigger word, and so it's just important to be mindful of that. Words that you should never use: transsexual, crossdresser, transvestite. They are offensive. I would not recommend ever using them. And transgendered is another word that it's recommended not to use. And the reason why is because transgendered makes it sound like that's something that has been done to a transgendered individual. And it sort of denies the fact that they have been transgender all along. And it also kind of helps perpetuate the stereotype that being transgender is something that happens after you've had medical interventions, after you've had surgery. And again, this is not something that's done to people. It's just a fundamental aspect of who they are and how that doesn't align with the sex that they were assigned at birth. If you take nothing else from this talk, please, please, please never use the word it. It is so amazingly dehumanizing and it's completely unacceptable. Please don't ever use it. And again, I know it feels like a lot. You're like, okay, I'm walking on eggshells. What do I do? When in doubt, just ask. I think that patients are we're so used to not having our providers actually talk to us and get to know us, because especially in dermatology, sometimes we're doing these things in like 10, 15, 20-minute visits. But taking the time to really engage your patients and to know them as a human being with multiple aspects of their identity, it goes such a long way to establishing really great patient-provider relationships, and it's definitely worth that time. Okay, tip number 2, when asking about sexual practices, don't make assumptions, and please continue using non-judgmental language. This is from a JAD CME from Ken Katz, Hao Young, Matt Manch, Clint Peebles, all the folks who are really doing the leading research on LGBTQ health and dermatology, and who I owe a great debt to for their mentorship. And I would highly recommend this 2-part review to anyone who wants to dig into the space a little bit more. I just wanted to talk about, like, how do we get that sexual history? And again, this is something that can be normalized. Hey, when I see a patient with a rash like this, I routinely ask about sexual history with my patients. So, normalizing it is important. And sometimes the language that we use has to be modified for our patients as well. So, for instance, when we're talking about anal sex, there's insertive sex and there's receptive sex. But if you said that to a gay man, they might not know what that means, but they may be familiar with the terms like top, bottom, or verse. So if you feel comfortable using those terms, that can be helpful as well. And again, like, please check your implicit bias at the door. Just because someone is a gay man doesn't mean that they're having like tons of unprotected sex. And it's really, again, important to understand that there are risks that go along with certain sexual orientation and gender identities. However, the person in front of you is a unique person whose individual circumstances need to be explored. Tip number 3, pay attention to the details. So there's other ways of demonstrating inclusivity as well. It's really important, even if you as a provider are doing the work, it's important this is a division-wide mission. If you have front desk staff or MAs who are hostile to LGBTQ folks, that's still going to end up being a very negative patient interactions. This is something where that education really needs to extend to the entire group who's providing care. I think collecting pronoun and sexual orientation information for the EMR is really helpful. That way the entire staff can use the proper pronouns. This has been rolled out, I think, in lots of sort of larger medical centers. I still think it's really important to ask at each visit, especially with folks who identify as non-binary or genderqueer, what are your pronouns, even if they're listed in the chart. I've heard people say, hey, like, it makes me feel like the patient's going to think that I don't know what's going on, that I'm not looking at their charts, if they gave the pronouns and I'm not using them and I'm asking about them. But, again, as we've talked about, sometimes folks' pronouns change, and really just checking in is another way that we can show, hey, like, I understand you and I want to respect you in the best way possible. It's also important to acknowledge that family can mean more than just biologic family. Unfortunately, many folks who identify as sexual or gender minorities have been ostracized or excluded from their families, and so they often have chosen families, and those folks are important in healthcare, and it's important to treat them as valuable members of the care team as well. Privacy, privacy, privacy. I will hammer this home. It is so important to just respect patients' privacy, to understand who they are out to versus not, and keeping those sorts of discussions, between you and the patient and anyone else who they tell you specifically that, they are okay with you sharing that information with. I think this is really important when we're doing telehealth, just to make sure that if you're having these conversations that you've made certain with the patient that there's no one else in the room who may hear information that they don't want them to hear. So again, just taking that extra step to make sure that you're maintaining privacy. I think signage is helpful. Rainbow stickers, non-discrimination policies, they at least show that it's a welcoming space. That is not like, I put up my rainbow sticker and my job here is done, but it can be helpful to just creating a welcoming atmosphere. And then having unisex or gender neutral restrooms is also helpful. There are so many other ways where we can work to make our spaces more inviting. Have you ever thought about what it might be like for a transgender person to have phototherapy? There's lots of privacy issues there. Both with respect to moving around a phototherapy unit, folks who may be actually providing the phototherapy, and if they know about the person's transgender identity. There's lots of places where I think we take the time to step back and say, hey, am I making the space welcoming? Am I thinking through these different issues? It's really important that we extend this to all the different ways that we provide care as dermatologists. Let's talk about special considerations for kids. Stigma and distrust of the medical community is probably there at baseline, but again, we know that this is ramped up in LGBTQ children who have experienced, stigmatizing or discriminatory interactions with healthcare providers. And if we make the healthcare space uninviting to children, then all we're doing is worsening health inequities because they just don't access care. So how do we guard against that? Privacy, privacy, privacy. It is really important to maintain your patient's privacy. And this can sometimes be tricky when we're talking about kids because parents may be filling out the demographic forms that you provide. To get around this, I typically take a sexual history for kids around 12 years of age. I don't say that I would do it uniformly. If someone's coming in for like a wart or something, it's probably not going to influence the care that I provide. But if there is something, a rash that may be related, that's certainly something that I do. And my patients who I work closely with sort of longitudinally, I make sure that I get that information as well. Please remember there are various stages of coming out. It's not just sort of like one day you're like, I'm out, I'm gay. For some people that is the case, but for other people, they let people that they know and love and trust know that in a slower kind of like gradual manner. And so what you don't want to do is accidentally out your patient to a parent or a friend or a family member who wasn't aware of their sexual orientation or gender identity. And then I just want to put in this plug again. This sort of harkens back to the beginning. It's really easy for us as dermatologists to be like, I'm a skin doctor, like this isn't in my lane, I don't feel comfortable. But I would argue that we are in fact really well equipped to provide the sort of supportive care that folks need. We have long-term relationships with our patients. And if you're prescribing a biologic, if you're seeing someone for Accutane, if it's even just a regular acne visit, right? You may be seeing them monthly to every 3 months. You're probably seeing your patients more than their primary care provider is. And so to say that like, oh, this is the role of primary care, it's not for me. It's really doing a disservice to this oath that we took to do no harm and to do best by our patients. And again, I would encourage you to really engage in the space because I have found from my own personal experience that it makes a difference in people's lives. Let's talk about the skin exam. Okay, respect as you would all other patients. There are special considerations, which I think are especially meaningful for transgender patients. Really, really important to convey action before inspecting or palpating, especially when we're talking about genital anatomy. Also, asking folks, how would you like me to name your anatomy? For instance, if a transmasculine individual, if you refer to their breasts, that may induce gender dysphoria. So it's just really important to understand how someone would like their anatomy like referred to. And then draping, again, very important just to make sure that patients don't feel like they're on display. One thing that is unique to transgender males and some gender diverse folks is the use of chest binders. And there's sort of two aspects of that. The first thing to know about chest binders is that they're used to reduce the appearance of breast tissue. And they're worn for multiple hours a day. So that can lead to scars, acne, infections, a whole host of problems just with that tight binding over the course of a day. It also might interfere with the total body scan exam. And again, I think that the most important thing to do is establish rapport with patients. So if a patient's like, I'm not really interested in taking off my binder, that's okay. Maybe we take the first visit to understand kind of what's going on. And at future visits, then when the patient feels more comfortable, then they may be more willing to not have the binder on perhaps before they come to the office, so that you can do a total skin exam, make sure that you're providing the best care possible. Okay, let's talk about dermatology relevant concerns for SGM patients and move into some of these disparities. So men who have sex with men are at increased risk of certain sexually transmitted infections. So these are things like chlamydia, gonococcemia, syphilis, HSV, HPV, HIV, and KS. Compared with heterosexual men, men who have sex with men have a higher incidence of anal, penile, and oral HPV infection. From the CDC, there's no guidelines as far as doing anoscopy, but there are certain medical centers who do anoscopy and pap smears just to make sure that they're not missing anal cancer. With respect to kids, there's not a whole lot of great data. We do know that there's an increased rate of STIs among children 15 to 19 years of age, but that's not broken down by sexual orientation or gender identity, so we don't have more information there. What we do know, however, is that about 5% of all new HIV infections annually come in children 15 to 19 years of age, and the majority of those are among men who have sex with men. So again, this is something that's important to be aware of, but again, don't make that assumption that everyone who comes in your room just has STDs just because they haven't had sex with men. There are recommendations from the CDC and other public health agencies for HIV and STD screening in men who have sex with men. This is again from that two-part review, JAD. The one thing that I just want to call out, and again, this kind of gets at that equitable care instead of equal care. So for men who have sex with men, STD screening is recommended regularly, and it's not just sort of like the typical areas. So when we're looking for GC or chlamydia, for instance, there may be like a urethral swab or a urine culture, but it's also important to recognize that swabbing the rectum and the pharynx are other areas that that need to be addressed as well. So again, there's nuances in this. It's something that you can partner with a primary care physician or an infectious disease doctor on, but it is important to be aware of them. What about women who have sex with women? So among women who have sex with women, the use of safe sex practices is lower because many of them do not recognize the risks, and they perceive themselves to be at lower risk for STD acquisition, in part in general, and then also they may use less protection because there's no risk of getting pregnant. That being said, there are higher rates of STIs in women who have sex with men and women, so bisexual women, than women who have sex with men only. And in some settings, chlamydia, oral HPV, BV, the incidence of those are higher among women who have sex with women than women who have sex with men. So there's definitely the possibility for sexually transmitted infections among women who have sex with women as well. It's just important to be aware of that. It's also known that women who have sex with women have a decreased pap smear use and HPV vaccination than women who have sex with men, perhaps because of a miscalibrated risk perception. So takeaway point, safe sex education is no less important for women who have sex with women than men who have sex with men, or anyone for that matter. So what's an active intervention that we can recommend? Hey, let's have people get the Gardasil. So this is the non-valent HPV vaccine. It's a 2 or 3 dose schedule. Current guidelines from the CDC, if for folks who are men who have sex with men or transgender, vaccination is recommended through age 26. This was relatively new over the past few years, and more recently that has been extended to everyone age 26 years or younger. The CDC has sort of muddling guidance on whether folks older than 26 need it. It's a discussion that's supposed to be had with you and your primary care provider, but it is suggested to at least discuss it with folks who did not receive the vaccine prior, who are age 27 to 45 years of age. And it may not feel like this in COVID times where there's lots of consternation around vaccines, but recommendation from a healthcare provider to get a vaccine is really important and can be meaningful. Let's talk about tanning. So men who have sex with men have 2 times reported non-melanoma skin cancers compared to men who have sex with women. And that's in part because they have a 2 to 6 times increase in tanning behavior, and they're less likely to wear sun protective clothing outdoors. So this is a high risk population for skin cancer. So what do we do about that? Let's do some tanning education. So this is very typical, I think, for many of our practices. The USPSTF recommends behavioral counseling regarding minimizing UV exposure for 6 months to 24 years in folks with fair skin. That's grade B, which is like, we suggest that you do it. For other adults, it's grade C, which is sort of like, we don't have a strong recommendation, but you can do it if you want to. I would argue that in folks, men who have sex with men, where we know that some protective habits are not great, it's really important to provide that counseling. And it's really important to explore the underlying motivations. So many sexual and gender minority sexual minority men recognize tanning as something that elevates their mood. There's perceived health benefits. They think that having tan skin makes them look better, and those are the reasons for it. But when you explain the costs associated with it, the potential for skin cancer, and that they may look like a leather handbag after years and years and years of tanning, that can sometimes help disrupt these not great behaviors. And I just need to point out, so one of my mentors at Penn, Chris Miller, he's a Mohs surgeon. He was like, you are not doing sun protection right unless you have a hat that's so big that it looks ridiculous on you. And I would say that you can pick a big wide brim hat that looks fabulous on you. And so you can still, have your fashion game on and protect yourself from the sun. So that's just my PSA, my personal one. Let's talk about poppers. This is something that many dermatologists may not know anything about. So poppers are inhaled alkyl nitrites. They come on different names, such as liquid incense, room odorizer, leather cleaner, video head cleaner, and they're used recreationally by men who have sex with men, typically because they have psychoactive effects and decreasing the sphincter tone, so it makes sex more pleasurable. It is important to know that if your patients are using this, if they're also using Viagra, that can lead to death because of hypotension, and just use of this at baseline causes hypotension, headaches, and arrhythmia. So it's not a very safe recreational drug to be using. How does this play out in the derm clinic? These alkyl nitrates can cause an allergic or an irritant contact dermatitis that can be rip-roaring. These are two examples from the derm literature. You can see here the inflammation and the vesiculation. This was on a gay man's hip where he had his poppers in his pocket and they leaked. For this man, he was hiding them in his sock and they leaked and caused an allergic contact dermatitis. This is from a man who got some of the poppers on his fingers and then touched his genitals. And that led to an allergic contact dermatitis that was later proven by patch testing. So again, right, the differential for an ulcer in the genital area of someone who is having sex is broad, but it is important that this is for you to keep this in your differential diagnosis as well. Just ask about potential use of these recreational drugs. All right, let's talk about acne. So acne affects 85% of children over their lifetime, and we know that acne in itself is a risk factor for depression, and that children who have acne have worse mental health outcomes or especially those who have severe acne than children who don't. This is especially relevant to sexual minorities because there's an exponential increase. So we know that folks who identify as LGB have higher instances of negative mental health outcomes, again, from stigmatization, from discrimination. Acne is its own independent risk factor for depression and anxiety. When a sexual minority individual also has acne, there's an exponential increase in depression and suicidality, estimated at greater than 1/3 of patients who are a sexual minority and have acne. To help guard against this, you can consider PHQ-2 or 9 as a screening tool to help make sure that you're keeping close tabs on your patient's moods. This is also important with respect to transgender folks. As I mentioned earlier in my talk, gender-affirming hormone therapy has been shown to improve mental health outcomes for transgender individuals. But folks who are receiving testosterone or masculinizing hormone therapy, there's a recent study from Braun and colleagues that was in JAMA Derm that showed that folks who had masculinizing hormone therapy, which is a known risk factor for the development of acne, who then developed severe acne, also had higher rates of depression and anxiety. So it's really important just to keep those things in mind. As I mentioned, masculinizing hormone therapy can trigger or make acne worse. More specifically, it seems that in addition to sort of the masculinizing hormone therapy in of itself, younger age of administration may be a risk factor, as well as blood testosterone levels greater than 630 nanograms per deciliter. To go through a comprehensive discussion of how to treat acne in transgender folks, it is an entire talk all by itself. But I do want to just call out that use of combined oral contraceptive pills are appropriate for transmasculine patients. This does not interfere with their transitioning process if they're on testosterone, and may be helpful to eliminate menstruation depending on the oral contraceptive that is chosen. These are discussions that are really important to have with an individual and to loop in their gender care provider, because we want to make sure that we are not causing or adding treatments that may interfere with appropriate hormone gender affirming therapy. Let's talk about isotretinoin. So what is the problem? So again, I don't want to harp on this because I definitely don't want to give the impression that everyone who is a sexual minority or transgender is depressed and suicidal. That is not the case. Many of us lead very happy and productive lives, but certainly, as I mentioned, these populations of which I'm a part of are at risk. And when you compound that with severe acne, that risk gets worse. My reading of the literature in terms of does isotretinoin truly cause depression and suicidality, it does not seem that that's the case. Those events may be more likely in folks who have a pre-existing mental health issue. I certainly, in my personal experience, have had a few patients that just kind of felt a little bit off, and so we stopped their isotretinoin. But I think that having a thoughtful discussion with folks and just letting them know the risk should not, depression and suicidality should not prevent you from initiating isotretinoin if a patient needs it. Scarring and wound healing comes up as well. There was a consensus statement that was published in JAMA Derm a couple of years ago looking at, is it safe to do surgery during or immediately after isotretinoin, and the group found that there was insufficient evidence to delay surgeries that are needed. So this is especially important for folks who are undergoing gender affirming surgeries. You don't need to stop the isotretinoin or have this delayed period of time before having the surgery. At least there's no evidence to suggest that there would be a problem. What about registering for iPledge? So this is the time I talk where I get excited and I give a huge shout out to Ken Katz and Clint Peebles and the folks who really run and are the beating hearts of the AAD Expert Resource Group on LGBTQ health. This has been a year-long struggle to change the really discriminatory identification process for iPledge, which has now been changed and it's still only based on reproductive potential that prevents transgender folks from being misgendered in the process. This is a huge win for us. I think everyone has their own feelings about how well the system was rolled out in December, and it seems to be better now, but this is one of the bright spots in that change. That being said, adhering to iPledge still can be problematic for transmasculine patients who can theoretically become pregnant. They still need to get pregnancy tests every month, and that can induce gender dysphoria. So it's really important to still have those conversations with your patients. And pregnancy prevention is important. It's also important to say this out loud that testosterone does not equal birth control. Folks can be on testosterone and still get pregnant. Transitioning, where are other avenues where dermatologists can play a role? I'm not going to belabor this, but for transgender men, they may need help with androgenetic alopecia or post-surgical scarring. And for transgender women, xerosis cutis and other cosmetic procedures like hair removal, facial feminization, scarring, and fillers. All right. What about in kids? What do we know? There's not a whole lot of data on this, but Pedra gave me a grant to start studying this, and I'm happy to share some of the results. So we did a study here of 118 children at our adolescent clinic here at Seattle Children's. That included 52 cisgender and 66 gender diverse or gender minority patients. And what we found when we asked, are there differences in the incidence of skin disease between sexual and gender minority youth and their cisgender heterosexual peers? What we found is that there's really no difference in the prevalence of all skin conditions that we asked about, most common like acne, atopic dermatitis, psoriasis, warts, just overall. However, when we did sub-analyses consistent with other results, acne was more common among transgender males who were receiving masculinizing hormone therapy compared to those who were not. There are really no differences in the prevalence of skin conditions based on sexual orientation. We did find that atopic dermatitis was more common in heterosexual adolescents, but I'm not really sure what to make of that. That may just represent kind of our smaller sample size. There are two takeaway points that I want to share with you. The one is that we asked folks, does your sexual orientation or gender identity influence how you personally feel about and take care of your skin? Based on sexual orientation, there didn't seem to be any difference. But folks had lots to say about how their gender identity influenced how they personally felt about their skin. So this was statistically significant that depending on one's gender identity, that really influenced, their concept of their skin and skincare. And we asked how. So these are just examples. And to summarize for you, for both cisgender women and transgender women, there was this idea that there was a greater societal pressure to make sure that skin was soft and dewy and clear, and that there's a societal standard that needs to be lived up to. And when these individuals who responded weren't meeting that goal, it made them feel worse about themselves. The response from transgender males was nuanced and very illuminating for me, because it really depended on the individual. So there's some people who just recognized, hey, once I started masculinizing hormone therapy, my acne got worse. And so I just need to actually start taking care of it. And for other folks, they're like, I see it as a rite of passage in some weird way. That's the patient's words, not mine. I see it as a sort of rite of passage, but also sort of, dealing with the, hey, I've internalized that skincare is something that's inherently feminine, and I shouldn't want to take care of my skin. So it's this sort of push-pull. And other folks, really just called that out succinctly and said, I don't take as many showers because it gives me dysphoria. And I don't take care of my skin because it's a feminine thing and it makes me dysphoric, the actual act of caring for their skin. So these are really important details to suss out with your patients, because if you're recommending a treatment program that they're not going to do because it engenders feeling of dysphoria, then we're not setting ourselves up for success. One other thing that was important that came out from the study is we asked sexual and gender minority teenagers, would you prefer care from a dermatologist who is also a sexual and gender minority? And both based on sexual orientation and gender identity, the answer was an overwhelming yes. And when we asked a little bit more details of why would that be, the responses that were given was just the expectation that someone who also identified SGM would be more sensitive and understanding and knowledgeable about SGM patients' needs, so patients wouldn't have to explain themselves, and that in turn would engender more trust between provider and patients. There probably aren't enough LGBTQ dermatologists to take care of all the LGBTQ patients in the United States, and that's why, if you're cisgender or you're heterosexual, your allyship means a lot. If you can provide this culturally humble care, my guess is that folks won't really mind getting care from a heterosexual or a cisgender provider, as long as you're meeting their needs. And so I, again, appreciate you being here with me today. So long-term change. Again, I want to emphasize the patient is not there to educate you. This is a step in your process of educating yourself. If you need more resources, there's many through Harvard, the Fenway Institute, the Sexual and Gender Minorities Health Equity Initiative, the CME and the JAD that I mentioned. These are all great starting or extension points for learning more about caring for LGBTQ folks. Again, developing relationships with all concerned family members and caregivers. It takes a village to support someone, and sometimes that village looks different from what we consider traditional models, and it's important to welcome those people into care and rely on them to help, if patients need it. Developing referral pathways to dermatology from gender clinics. I mentioned that as sort of a sticking point, but if we can develop those, that's going to be super helpful, and again, zero tolerance for discrimination. All right, take-home points. Respect goes a long way. When in doubt, ask. Men who have sex with men tan at greater frequency than their heterosexual counterparts and are at increased risk for skin cancers. There is an association between acne and depression that makes things exponentially more acute in sexual and gender minority patients. iPledge can still be problematic for transgender males despite the advances that we've made recently. Teenagers see their skin as a reflection of themselves. So maybe there's a role for psychological support. Maybe there's ways that we need to be engaging them further. And sexual and gender minority teenagers prefer providers who reflect their own experience. If you are out and proud and feel safe in your community to identify as such on your website, I know that's not the case for everyone. This country is not necessarily safe for LGBTQ folks everywhere, but if that's something that you're willing to do to identify yourself as such, I think it will make a huge difference for kids and adults who access care with you. I want to end on this, getting back to this idea of intersectionality. Justice is intersectional. So if you care about LGBTQ folks, then you should care about Black lives. you should care about climate change. All these movements are often siloed up, and as dermatologists sometimes we feel afraid to engage with them because it feels too political and what might we do. But what we're trying to do is create a more just society where people are valued and appreciated and honored and supported for who they are. I hope, if nothing else, you take away from this that you can make a huge difference in people's lives if you're just willing to go there a little bit. It is by far, doing this work and caring for sexual and gender minority children is just, it gives me so much joy and purpose in my day-to-day life. And I'm on a personal note, I just came out 6 years ago, so this is still new for me, and I see the world changing for the better for folks, for young folks, and I hope that we can all be a part of that because it makes such a difference. Thank you so much for your time and attention, and I'm happy to take any questions.
Great, thank you so much. What a wonderful talk, and I personally learned so much. Just we're so grateful to have you here today and to share your expertise with us. I'll start out by just asking kind of a broad question. Thinking about dermatology residency, what steps either at your institution or have you seen others taking at their institutions to sort of build in some of this education in the standard, dermatologic residency education, things that work and things that don't work?
Yeah, I think that it's sort of twofold in my role in UW residency education, right? So part of it is intentionally including talks like this in the regular curriculum. And I think too, right, like one effort that we have been doing at UW is saying like, hey, like if I'm giving a talk on psoriasis, for instance, what are some like populations that we don't think about that I need to like discuss, that it may present differently, right? Skin of color, for instance. How does this manifest, or how does treatment change based on other aspects of someone's identity? So it doesn't even have to be like, oh, like here's your DEI talk, right? Like I think that we run the risk of people being like, oh my gosh, like I still need to learn the basics of dermatology. I feel lucky that I'm in an institution where, DEI work is valued and encouraged. But sometimes like we just need to intersperse it here and there throughout the lecture. So that's what I try to do, and I think it's really helpful. And then certainly when I have sexual or gender minority patients in my clinic, then I provide those, the residents that opportunity to go and see them first. And, oftentimes like I'll go and ask the patient like, hey, is it okay? Like I have a resident with me. And that's also why I think as an attending, like establishing that rapport is so helpful, because it allows the patient to trust that other people that you will bring into their sphere will treat them respectfully as well. And then we do a quick debrief beforehand. Just to say like, hey, okay, like, do you feel comfortable? Like, how are you going to ask these questions? And so it's that like real-time learning that I think can make a huge difference as well.
That's great. Thank you so much. It kind of leads into another question, particularly, in patients that are less than 18 years of age. I can imagine there might be some situations that the parents and the patient might not necessarily be on the same page. And just any insight or suggestions on how to, take a history versus, actually make medical decisions and, how the parents.
Yeah. I mean, I kick the parents out of the room. Yeah. And I think that's like the most important thing. And again, like it feels so awkward sometimes. And also I try to normalize it. And I just say, hey, when I have, patients who are teenagers, I like to give them the opportunity, and a way that you can kind of spin it that makes it less like, we're going to talk about sex, drugs, and rock and roll. Let's be like, I like to give teenagers the opportunity to start learning how to advocate for their own healthcare. And so I'd like to talk to, your son or daughter alone for a little bit. And sometimes I get like a little bit of a side eye, but I say the majority of parents like, cool, like they kind of come to expect it. And again, I don't know, right? I live in a very liberal area. Seattle is uber liberal. That being said, the surrounding communities become rapidly less liberal. So, like I work with families of lots of different viewpoints, and regardless, I can't say that I've gotten tons of pushback on that. And then it's really a question too, and I'll say this again, why I appreciate my position here at Children's is that I get 20 minutes with all my patients, whether they're new or return. And so I don't feel like, oh my gosh, like I only have a 5-minute visit. And like now I have to get into this, right? Like I want to get into it because I know that it makes me a better doctor. And so really taking that opportunity and then talking with the patient, being like, hey, like this is where you're at. Your family may or may not know. What role do you need me to play right now? And asking, right? Teenagers never get asked anything. And then we wonder why we never hear from them, right? But if you take that time to ask, they have lots of opinions and they'll tell you what they need from you. But the question is not to assume what they need from you, but to say like, what do you need from me? And what does that look like? And they might be like, I don't need anything, just like keep it to yourself. And then it's important to sort of know what your EMR looks like and who has access to it. At our institution, as far as like my chart and stuff like that, the parents can only have access to it if the kid like signs and gives consent to that. So just sort of like understanding who has access, because there may be ways that like I will make a note to myself if I am concerned that someone else will read it who isn't supposed to know. So it's sort of like a coded language for me that I'll understand at the next visit, versus just kind of like putting it out there. If you know that, no one who's not supposed to know is going to have access to that information.
Super. Yeah, that's really helpful. I'm glad we have a couple questions from the audience coming in. So City asks, thank you so much for the much needed talk. Do you have any recommendations for trans mass patients early in the transition process that are currently struggling with acne? Many are on the fence about transitioning, so they don't have to fight acne in their second puberty. The distress from gender dysphoria versus acne is a lot. Your thoughts?
I think it depends a little bit on sort of like where they are in their like gender affirming hormone therapy. So sorry, I'm gonna bring up the if it's in the Q&A. Okay, I missed it. So I guess a few things to know about acne. So so when it comes to transitioning, I think the important thing to know is that there's sort of like two components to it. Okay, so the first one is pubertal blockade. Okay, so that's used to something like Lupron. It's GnRH agonist that basically pauses pubertal development. And at that point, it's completely reversible. If a child, ultimately decides not to medically transition for whatever reason, then you stop the medicine and sort of like natal puberty progresses as it was going to. And there's not like a whole lot of data behind this, but in some older studies from about like 20, 30 years ago, use of GnRH agonists actually was used in women who had PCOS, and it actually cleared up their acne. So there's some evidence that like use of that may prevent, like bad acne. If we're, like on the fence about starting and there's already acne happening, and the concern is, hey, like starting testosterone, for instance, is going to make it worse. Yeah, that's sort of like, it's a fraught situation. And again, I think that like the big thing to do is take the time and talk with folks about it and be like, hey, here are the potential risks. And also, how does, let's assume that you get acne. One way that we can do it is maybe dropping your weekly testosterone dose. And so there's ways to work with like the gender care provider too, to see. But, if someone has made a decision to start masculinizing hormone therapy, kind of going down on the dose may give them like a sense of unease too, because like, well, I'm not doing all things that I can to like, affirm me in this transition. And so I think kind of like a discussion amongst all, stakeholders is really important. And then discussing the different things, right? So topical therapy really doesn't differ between transgender and cisgender folks. But once we start talking about systemic therapy, if you are transfeminine, for instance, you as a provider do not want to give a transfeminine patient more like an OCP with estradiol in it, because they're already getting estradiol as part of their gender affirming hormone therapy. And so that could increase risk of like venous thromboembolism and all sorts of complications. So, there are certainly some things that like you do for transfeminine patients that you might not do for transmasculine patients, and vice versa. So kind of getting at that with systemics. But I think that, it's just an honest conversation about sort of like, these are the potential risks. These are the blocks that we still have to kind of overcome. iPledge, for instance, right? I think that, when I discuss it now with my transgender patients, I let them know that there used to be a really offensive way that we had to register folks. And now it's just, are you of childbearing potential or not? They're always excited that that's the case, especially folks who had already been in the program and now we got to transition that. And then there's the follow-up, which is like, you still have to take a pregnancy test every month. And, you know, it's met with, I think, a little bit of disappointment. And I try to explain to them that what we're doing is navigating the sort of providing them the justice to sort of identify as who they are, while also making sure that we are staying safe. And I think that a lot of patients can understand that. But again, it takes time. You can't just be like, oh, this is how it is. Good luck, right? If you take those moments, it makes a huge difference.
That's great. Thanks. Well, you know, it's the top of the hour. I want to be respectful of your time. We do have one more question within, you know, a minute or two. And it's actually, I think it's a nice way to close. It comes from Ning, and the question, I'll just paraphrase for the interest of time, is, you know, what areas do you think require more research and exploration?
There's a lot. I think one thing that, to me, I think acne, right? There's still a lot for us to figure out there. There's been lots of reports from different groups kind of looking at the risk factors for the development of acne. One thing that, you know, for me, I find is interesting is, so as I mentioned in my talk, like use of oral contraceptive pills, you can do that in transmasculine folks, and it's not going to interfere with the transitioning process. We use OCPs to treat acne, right? Will they work? I don't know. And I'm not sure that anyone has ever looked at that, right? I think there's other ways where you can say like, hey, we can sort of understand the impact and the utility of agents that we use sort of, you know, traditionally without thinking too hard about it in cisgender folks, but they may have different implications or efficacy in other populations. I just think that's an important question, right? Someone may, a transmasculine patient may want to be on an OCP so that they don't bleed, right? Because the act of menstruating may cause gender dysphoria. So there's a good reason for that that's independent of the acne, but does it actually help with the acne? You know, one other place too, so clascoterone, so that's the topical anti-androgen that was just recently approved for the treatment of acne as well. It's twice daily application. In that study that was published in JAMA Derm recently, it seems like they only recruited cisgender folks to the study. Does, you know, what's the efficacy in transgender folks? You know, you might expect that it would be great because it's really like directly at the level of the skin, blocking that negative effect that masculizing hormone therapy can have on acne. At the same time, if you have high levels of testosterone from gender affirming hormone therapy, is it going to be as effective? We don't know. So I think that there are other places we can really understand like what are the benefits, and more sort of like thoughtfully and accurately, you know, provide those recommendations for our patients.
Thanks.
And there's lots, I think, too, with like, you know, safe, like cosmetic care. It's just so far outside my realm as a pediatric dermatologist. I don't provide it, but I do think that's another way that's really important in supporting transgender women, especially because, you know, for filler, like body fillers, sometimes people use and inject things into the body for like contouring purposes that can be really harmful. And so, you know, seeing that as part of our role, or maybe in conjunction with plastic surgery, I think, you know, there's definitely ways that we can be better advocates to communicate the risk and then also be a part of the solution.
Thanks. Well, this was really just a great talk, and I can't thank you enough for joining us today.
Yeah, thanks for having me.
Amazing. Thanks everyone for tuning in. All right. Have a good day, everyone.
You too.